please formally, Yashasvi, you take over.
Okay, sir. Okay. Good evening, everyone. I'm Yashasvi. I'm postdoctoral trainee at Department of Endocrinology, NRS Medical College. I welcome you all to another 4E webinar being organized by the Endocrine Society of Bengal. I'll just share my screen once. One second. Indira ma'am, actually you are the host. I think you'll have to enable the sharing from your end for my screen if you can.
Right now I have not shared anything.
No ma'am, you'll have to enable my screen to be shared, ma'am. Actually you are the host. So
okay. So where do I enable?
Ma'am, in participants, if
Yes.
you could go and just click on more and
you are in the Endocrine Society, right?
Yes,
The Endocrine Society.
Yes,
Make host. Okay.
Thank
oh,
you.
I
So
okay.
So the topic for today's webinar is my screen visible?
Yes.
Is my screen visible? Is
yes.
Minipuberty and its implications, which is a very interesting topic and also very helpful, especially to us trainees. Today's session will be chaired by Professor Asish Basu, sir. He's a retired professor and head of Department Endocrinology and also the ex-principal at Medical College, Kolkata. He has been the Secretary of Endocrine Society of Bengal. He's the President of IPGMER and Endocrine Alumnus Association. He's the examiner and thesis educator of DM Endo courses and has more than 50 publications in national and international journals. Thank you so much for joining, sir, and agreeing to be the chairperson. The speaker for today's session is Dr. Indira Maisnam, ma'am. She is Senior Consultant Endocrinologist, Department of Endocrinology at RG Kar Medical College, Kolkata, Charnock Hospital, Bellevue Clinic, and also RSV Hospital. She has 52 publications in PubMed indexed national and international journals, scientific paper presentations in international conferences. She has been invited for many lectures in state and national conferences and is also a reviewer in many journals. Thank you so much, ma'am, for joining us today. I now request Professor Asish Basu, sir, to please take over the session. Thank you, sir.
Thank you all for your gracious participation in this evening. I'm really grateful to Professor Nilanjan Singh Gupta for giving me the scope of chairing a hardcore endocrinology topic. It's really hardcore. And you know that endocrine science is expanding like anything, more than a jet speed. And Minipuberty is one of the topics which is very much crucial, important for the clinicians, endocrinology practitioners. You know, the Minipuberty was first described by Forrest et al. In the year 1973. Minipuberty is it's sort of reactivation of HPG axis after in the neonatal period, nearly about 2 weeks due to the withdrawal of the placental steroid, particularly the placental estrogen. And Minipuberty in the boys, you know, it gives rise to increased LH, FSH, and testosterone. The peak level at about 3 months, and then it persists and comes to nadir at about 6 to 9 months. And there is increased level of LH, FSH, testosterone. LH is more than FSH, and it has a important implication and has a correlation with the mini-puberty because it is very important for the growth of the genital organs, testicular adhesion, and the masculinization of brain and the male psyche, and the growth and proliferation of Leydig cells, Bartoli cells, and increase the seminiferous tubules. So germ cell increase. So there is testicular volume increment is there, and priming of the pilosebaceous unit and the somatic growth. And in females, the definite correlation is not that robust. And the females, some authors have their own findings that in females they do have some correlation with the breast diameter and also some psychological and changes, but not as prominent as in the males. So that is the important observations. In females, it's like the male, the FSH, LH, and the estrogen level rise, and the FSH more than the LH. And again, from the 2 weeks onwards, the peak 3 months, but may persist up to 2 to 4 years. And the estrogen level is fluctuating rather, not like the testosterone, because the cyclical maturation of the ovarian follicle. So, ladies and gentlemen, it's a very interesting chapter, and our today's speaker, Dr. Indira Maisnam, does not need much introduction. She is erudite and already made his mark in the endocrine academic world of our state and also in India. She will navigate her discussion, taking stock of all the findings, research, clinical clues, and take us to the sojourn of mini-puberty. So, without wasting any other time, I invite Dr. Indira to start our deliberation. Dr. Indira, please.
Thank you, sir. Thank you for your kind introduction and beautiful summary of what I'm going to present today. Thank you, Endocrine Society of Bengal, and thank you, Dr. Nilanjan Sengupta, Dr. Shoumi Goswami, for giving me this opportunity, this honor to be speaking in this platform, which is a very important and interesting topic, an evolving topic, that is mini-puberty and its implications. So how do we define mini-puberty? It is transient. So it's a transient sex-specific activation of the hypothalamo-pituitary gonadal axis, which occurs during the neonatal period, which results in high gonadotropin and sex hormone levels. It was first described by Forrest et al. In 1973, as has been pointed out by Professor Basu. So if we look in the life of an individual, there are 3 periods of activity of the hypothalamo-pituitary gonadal axis. One is during the mid-gestation, and then after that is in the fetal life, as we can see here. One is in the neonatal period, which we call the mini-puberty, and there is the stage of puberty. We know that the Leydig cells of the testes secrete testosterone, and in the first half of pregnancy, it is mainly under the control of the human chorionic gonadotropin, which actually stimulates the Leydig cells of the testes to secrete testosterone. Thereafter, around 15 weeks, the olfactory, gonadotropin releasing hormones, neurons of the GnRH migrate from the olfactory pit or the placard to the hypothalamus. And around 9 to 10 weeks, we can see that the pituitary has gonadotropins, but the actual secretion takes place at around 12 to 14 weeks into the circulation. So in the initial part, the control of the testosterone secretion from the testes is taken over by the HCG, but later as the HCG comes down and as the pituitary gonadotropins get to secrete more and more gonadotropins, it is taken over by the by the gonadotropins, and then there is a release of the testosterone. And also along with it, under the control of the FSH, we know that in the testes there is maturation of the Sertoli cells, which results in the regression of the Mullerian drug, and the presence of testosterone and dihydrotestosterone results in the masculinization of the fetus in the form of the development of the Wolffian ducts and also of the external genitalia. In the females, we know that in the absence of the anti-AMH, in the absence of the testosterone, there is regression of the Wolffian ducts, and there is development of the Mullerian duct structures into the fallopian tube, the uterus, and upper vagina. So all this maturation takes place, all this development takes place during the gonadal steroid surf that takes place in mid-gestation. Now, as the gestation progresses and as the placental estrogens keep on increasing, there is a feedback on the hypothalamo-pituitary gonadal axis, so that at birth, the FSH and LH are low in both sexes in the cord blood at birth. In boys, the LH increases approximately 10 times in few minutes after delivery, and resulting in a rise in the testosterone, which is sustained for 12 hours. This does not occur in girls. After this is the setting of the minipuberty. So the most accepted concept, the mechanism for the setting of minipuberty, is that after the delivery, as the levels of the placental steroids, that is a placental estrogen, wanes or decreases, there is a loss of negative feedback, and there is reactivation of the hypothalamo-pituitary gonadal axis. So gonadotropins rise at around 1 week of birth, after 1 week of birth. So there are certain differences, again pointed out beautifully by Sir. So in boys, the LH begins to rise by 1 week and reach adolescent values by 1 to 2 weeks. It peaks at 1 to 2 months of life and decreases to prepubertal levels at 4 to 6 months. And the pattern of testosterone secretion also follows the pattern of the LH secretion, which I shall show in the next graph, in the next slide. And FSH also follows similar pattern, but the amplitude is much lower. In girls, again, the pattern is similar in girls, but the lower peak of LH rather is the FSH that is higher and higher in females than in males. FSH is higher than LH, and FSH can remain elevated definitely at 12 months, but sometimes up to 3 to 4 years also. Unlike the testosterone levels, which are steady, the estradiol levels fluctuate in the neonatal girl. So what are the consequences of minipuberty on the reproductive system? So let's take the boys into consideration. First, the increase in the LH, the LH surge increases in the Leydig cells, which increases the testosterone secretion, and also the penile growth and the further descent of the testes. If it was not descended. So at the the growth of the penile growth is at the rate of 1 millimeter per month for the first 3 months. After that, it can continue to grow till 3 years. The increase in the FSH results in the elongation of the seminiferous tubules, results in the increase in the Sertoli cell numbers, and thereby there is an increase in the testicular volume. So the testicular volume increases first in the first 5 to 6 months from around 0.27 cc's to around 0.44 cc, whereas thereafter it comes down to 0.31 cc at 9 months. Also, there is a secretion of the AMH and inhibin B, which we know are markers of Sertoli cells. And under the effect of the hypothalamo-pituitary gonadal axis activation, the gonocytes also transform into adult spermatogonia, and the germ cells proliferate in the first 100 days of life, setting the stage for future reproductive fertility and reproductive potential. And therefore, the setting of minipuberty is important for further maturation of the male reproductive organs, and is the completion of the work that was, it may be taken as a completion of the work that was initiated in the intrauterine life. So if we look at the patterns of fetal luteinizing hormone, FSH, and testosterone secretion, we see that the LH secretion is much more than the FSH secretion. So with a peak that occurs, let's say, around 1 to 2 months. And then after that, 12 weeks, with a peak that occurs around 1 to 2 months. And we see that the FSH also follows a similar pattern, but then the amplitude is much lower. And again, the testosterone secretion follows the pattern of the LH secretion. Now, what is the consequence of minipuberty on the reproductive system in girls? So coming to the estrogen levels in cord blood are similar in both sexes, whether it is a male child or a female child. It are similar in the cord blood in both sexes, and falls in levels in both sexes after birth. And we know that the effects of the placental estrogen starts wearing off by around 1 week. And then it falls off. But in the female, the estrogen again rises in females, and it starts 1 week post-delivery and remain elevated for more than 6 months, like it could be 1 year or more. It peaks at 3 months. There is a marked fluctuation in the estradiol level, unlike the testosterone level, which was steady. And this is due to the cycles of maturation and atrophy of the ovarian follicles. So what is the effect of this minipuberty in a full-term girl? So the breast size in both the male and female infants or neonates are similar at birth, but then the breast size, the diameter of the breast actually increases in the girls, and this is the effect of estrogen. What about its effect on the uterine growth? Most of the uterine growth has taken place in the intrauterine life, and some continues with the maximum growth up to 7 days. But at 7 days, the minipuberty has not yet set in. So probably the effect on the uterine growth does not take place in the full-term girl, but definitely it results in a larger diameter in breast in the girls. So these are the patterns where we see that the LH, so the LH is this one, where the peak of the LH is much lesser than the FSH, and we see the pattern of estradiol, which is fluctuating, unlike the steady state which we saw in male infants. And this transient hormonal rise are usually not clinically obvious unless we search for it. But sometimes, yes, they can result in vaginal bleeding and breast enlargement in girls, and testicular growth. So the testicular increase in volume, like I have said, but typically it is not a very obvious or a palpable testicular growth, but sometimes it does happen, and there could be pubic hair development in boys. And most changes are not otherwise clinically not visible. So what about the minipuberty in the preterm infants? So in preterm infants, so this is the graph of the preterm infant, whereas this is the graph of the full-term infant. So the trends are similar in the preterm and full term, but with a significantly higher peak or higher amplitude in the preterm. And there is a positive correlation between the degree of the hypothalamo-pituitary gonadal axis activations and the grade of prematurity. And therefore, the purpose of this activation is to complete the genital development that was initiated but somehow incomplete during the antenatal life. But after this, the waning off is actually similar in terms regarding the postnatal age. So ultimately, what I'm trying to emphasize is that yes, the pattern is similar, but there is a greater amplitude because there is a greater need for further maturation of the axis. So yes, the values are higher and is more elevated, and the peak is more prolonged. This is because the placental estrogens may not have yet reached their peak, and there also the immaturity of the negative feedback system in the hypothalamo-pituitary gonadal axis. In premature girls, what we need to remember is that there is a stronger association between the postnatal estradiol surge and the growth of the mammary gland diameter and the uterine length. So here in the preterm girls, there is also a contribution of this minipuberty to the growth or the further enlargement of the uterus. And in the boys, it results in faster penile growth and also the testicular growth, including the testicular descent if that was not complete. So what about minipuberty in smalls for gestational age? We know smalls for gestational age in children, this one fetus and later infants actually have metabolic economy, so that the nutrients are diverted to immediately more important organs like the brain and the nervous system, whereas there is a compromise in lesser important organs at that moment in life, like the reproductive system, the organs of the reproductive system. So yes, there is a programming of metabolic economy, and this results in insulin resistance. And we know that in the pubertal year, insulin resistance is associated with ovulation defects in girls, and also they could be premature puberty. Smalls for gestational age and high catch-up growth is also associated with cardiometabolic disease. So what is the effect of small for gestational age, let's say, on the reproductive organs in females? There are lower ovary and uterine size, and also lower testosterone volume and testosterone, and maybe lower fertility capacity in later life. The results of the effect of small for gestational age on minipuberty is mixed. Now, what are the consequences of minipuberty beyond the reproductive organs? So does it have any role in somatic growth and body composition? And what about its effect on neurocognitive and behavioral aspects? So regarding the somatic growth and body composition, greater growth velocity in boys compared to girls has been supposed to be due to greater testosterone, and the greatest growth velocity difference of 4.1 centimeter per year is at 4 weeks, which coincides with the peak of the axis activation, especially of the testosterone. It may be associated with testosterone that is elevated at the time of mini-puberty, may be associated with greater lean mass in boys. And also estrogen directly is correlated with skin fold thickness and adipose tissue in girls. What about the neurocognitive development? We know that the brain has immense plasticity at this time. What I found very interesting was that early linguistic in girls with greater degree of complexity may have some attribution to the mini-puberty, because estradiol at 4 weeks is associated with the melody complex index. So what is this MCI, or the melody complex index? Is the index of the infant's frequency modulation skill, providing melodic primitives for language. So so we know that girl child or girl infants pick up words and speak sentences much faster than boys. This could be the reason. And in fact, testosterone at 20 weeks negatively correlated with the infant babbling skills, and free estradiol at 5 months positively correlated, and testosterone negatively correlated with sentence comprehension at 4 to 5 years. What about other findings? What about the gender-linked play behavior? Like, are girls supposed to play with dolls and boys supposed to play with cars? So there has been consistent finding regarding the gender-linked play behavior with the mini-puberty. But there seems to be positive correlation between testosterone and the Q-chat. That is the quantitative checklist for autism in toddlers and the autism spectrum disorders. Anyway, these are inconsistent findings, and therefore they need more research on it. Now, mini-puberty in disordered sex development or disorders of sex development. So let's take the case of hypogonadotropic hypogonadism. So in hypogonadotropic hypogonadism, that there is the absence of the LH and FSH and gonadal steroid surge. So infants with hypogonadotropic hypogonadism present typically with micropenis and cryptorchidism or cryptorchidism, because the later parts, the later development of the male genital system in the form of the enlargement or the growth of the testes and the growth of the penis and the descent of the testes has to do with the hormones, with the testosterone and other substances that are secreted from the Leydig cells under the influence of the LH and under the influence of the pituitary gonadotropins. At the same time, patients with hypogonadotropic hypogonadism actually do not have, let's say, abnormal development of or impaired development of the male internal or external genitalia in the form of, let's say, the Wolffian duct structures, etc., because those organs or those parts are developed at the time when the testes are under the control of the human chorionic gonadotropin, which is there in pregnancy. And also it is not associated with hypospadias because the urethral meatus closing takes place much before the influence of the gonadotropins take place. So what is typically found in hypogonadotropic hypogonadism is micropenis with or without cryptorchidism. So when we see a child with such features, we should assess for the presence or absence of minipuberty. So the best period to measure the serum reproductive hormones is at 4 to 8 weeks of life, but can be performed until the 6 months of age. So again, we may ask the question that is cryptorchidism leading to the infertility, or the hypogonadotropic hypogonadism leading to failure of the testicular descent, leading to cryptorchidism and also infertility. Because we know that orchidopexy alone does not necessarily improve infertility in the cryptorchid. Targeted therapy with gonadotropins analogs following successful surgery results in normalization of the sperm parameters in adult life, which may improve fertility. And so impact minipuberty as a cause of cryptorchidism associated with infertility. But at the same time, let's say we have a 46XY male who has got undetectable testosterone level, who is cryptorchid and has got elevated gonadotropins level. Obviously, in this case, it is not a hypogonadotropic hypogonadism, but could be something like congenital anorchism or the vanishing testes or the testicular regression syndrome. Now, I think we have been using testosterone for the treatment of both cryptorchidism and as well as micropenis in children with congenital hypogonadotropic hypogonadism. So what are the promises and what are the limitations? Yes, it induces penile growth. It also induces testicular descent, the use of testosterone, but it does not increase the testicular growth. It does not increase the testicular growth and thereby of the development. And if it is done with along with an orchidopexy, there is also a chance of trauma to the testes, and it cannot ensure fertility. But at the same time, I would like to point out is that if a neonate has undergone an orchidopexy and then a normal minipuberty ensues, then the chances of a good supply of adult spermatogonia for future spermatogenesis is there. So what about recreating the hormonal milieu of minipuberty with gonadotropins in congenital hypogonadotropic hypogonadism? So the first report was given by Main et al., where they use LH, recombinant human LH and FSH, and it was found that the penile length increased by 50%. And also there was an increase in the testicular volume. When there is an increase in the testicular volume, we know it means that there is an increase in the length of the seminiferous tubules. We know that there is an increase in the Sertoli cells, and also there is an increase in the germ cells. So which could mean that it could improve the future potential of fertility. The REMAP study investigated the use of recombinant LH plus FSH in 10 neonates and infants with micropenis and cryptorchidism due to hypogonadotropic hypogonadism. And what did they find? That all patients increased height velocity. The LH levels increased from undetectable levels to high normal. FSH reached supranormal levels, and markers of Leydig cells as well as Sertoli cell functions like inhibin B, AMH, and testosterone reached normal levels. So that therapy may have induced a high normal activation of both the Sertoli and the Leydig cells, not only improving the, let's say, the penile length or let's say the testicular distance, but restoring the testicular endocrine function that could have a role in improving future fertility. And for this, there was an article in the Nature Reviews Endocrinology where it was shown that yes, the use of neonatal gonadotropin in male congenital hypogonadotropic hypogonadism did increase the testosterone levels. In many of them, there was increase in the inhibin B and also inhibin B and AMH levels. In Turner syndrome, the perinatal FSH secretion is similar to that in healthy girls. Again, Turner syndrome is has got like the pattern of FSH secretion is related to the karyotype. For example, girls with monosomy for Turner syndrome exhibit a persistent elevation of FSH up to 6 years. Whereas if it's a mosaic form with some, let's say some ovarian function may have elevated FSH values, suggesting feedback effects on the HPG axis due to retained ovarian function. Again, the data on of minipuberty in Klinefelter syndrome is mixed and contradictory. Just to give a study of different idea of different studies. In some studies, they showed that there was a decrease in the testosterone level, whereas in others, the LH, the testosterone LH, inhibin B, and AMH were not different between the groups. However, the FSH levels, it was higher in the Klinefelter syndrome group. So yes, the data on even Turner syndrome, on even in Klinefelter syndrome, on the effect of these disease conditions on minipuberty is mixed, and this is because of the heterogeneity of the conditions also. What about minipuberty in androgen insensitivity syndrome? Androgen receptors play an important role in the HPG axis activity. Surprisingly, when the study was done, it was found that complete androgen insensitivity, we may think that it would be associated with increase in the LH and the FSH, but rather complete androgen insensitivity do not exhibit the physiological peaks in the LH and consequently testosterone during minipuberty. In fact, there is no peak at all. So there is absolutely absence of peak, but because the sex is chromosomal sex is XY male, the pattern of the gonadotropins is LH, FSH. So there are many unknown factors actually what determines this ratio of the LH, FSH. Whereas in partial androgen insensitivity syndrome, there is a high, as expected, there is a high normal levels of postnatal testosterone and LH. So this comes back to the point that what is responsible for the, let's say, suppression of the axis at the later parts of pregnancy, and again, the reactivation in the early postnatal life, that is after 1 week. So rather than just estrogens, the androgens could also have a role in modulating the HPG axis in the intrauterine and in the postnatal life. So the postnatal gonadotropin surge may represent response to withdrawal of definitely estrogens, but also androgens, both in male and female. In males, testis was a source of androgen, whereas female, the maternal androgen may play a role. So again, this is an interesting study which I found where they try to find out the sex differences in the reproductive hormones during minipuberty in infants with normal and disordered sex development. They took a large number of healthy infants of 1,840, and patients with DSD between who were 27 in number, aged 2 to 5 months. They looked at a number of hormonal parameters, which include LH, FSH, testosterone, estradiol, sex hormone binding globulin, inhibin B, anti-Müllerian hormone, DHEA, DHEAS, 17-hydroxyprogesterone, androstenedione, and the LH-FSH ratio. And it was a large number of individuals, which include Klinefelter syndromes, which include Turner syndrome, androgen insensitivity syndrome, and also congenital hypogonadotropic hypogonadism. So what were the results? The LH and FSH concentration showed overlap between the sexes, with LH being highest in the boys and FSH being highest in the girls. The LH-FSH ratio separated infant boys from girls with minimal overlap at a cutoff value of 0.32. So an LH-FSH ratio of this separated boys from girls, chromosomal boys from girls. Inhibin B and AMH concentrations were markedly higher in boys compared with girls with minimal or no overlap. So inhibin B and AMH were discriminatory for boys, means they were in infants with Klinefelter syndrome and Turner's, different varieties of Turner's, mosaics, and male phenotype and Turner syndrome, the LH-FSH ratio matched the gender of rearing. However, infants with chromosome CAS or the complete androgen insensitivity syndrome who have a chromosomal sex of XY had the LH-FSH ratios within the male range. So they concluded that the classifiers that best separated sex in mini-puberty were AMH, LH-FSH ratio, and testosterone. And the use of the LH-FSH ratio may add valuable information in the work of infants with suspected of DST. Now, what about the endocrine disrupting chemicals? We know that endocrine disrupting chemicals have a role, affect almost every endocrine organ in our body, and they have got far-reaching consequences on pubertal onset. But it has been seen that endocrine disrupting chemicals may interfere with the HPG axis activation in the fetal life immediately after birth, that is at the time of mini-puberty, throughout mini-puberty, and also during puberty. Just to give an example of some endocrine disrupting chemicals which are present, which are widely present, bisphenol A, let's see the effects on mini-puberty, can lower the testosterone level. Phthalates can lower the testosterone LH ratio, can result in undescended testes, hypospadias, and shortened AGD. And others like DDT and DDE can cause the undescended testes and hypospadias. And also we see that many more endocrine disrupting chemicals have marked effects on the mini-puberty and also puberty. Now we need to ask ourselves why mini-puberty is not overt puberty. For example, there is no, let's say, reproductive potential example. So because we know that it is a transient state firstly, and also in mini-puberty, it is a transient state of physiological androgen insensitivity of the Sertoli cells. So the androgen receptor expression in the Sertoli cells are absent or very low in the neonatal years, and then they start appearing, let's say, around 1 year, and then there is a progressive increase in the observed androgen receptors between 2 to 8 years. At pubertal onset, when there is at 9 to 14 years of age, all the Sertoli cell nuclei are androgen receptor positive and respond to increase of local androgens with signs of maturation, AMH downregulation, massive entry of germ cells into meiosis, and thereby of spermatogenesis. So that is why mini-puberty is not overt puberty. To summarize and conclude, mini-puberty plays an important role for the further maturation of the sexual organ. It is very well established in boys. How clear it is in girls is not known, but definitely there are reasons, and also in preterm neonates. It sets and refines the foundation of future reproductive potential. And it seems to influence growth, body composition, and neurocognition. However, more research is required in this area. It is a window of opportunity to examine the hypothalamic-pituitary gonadal axis in those whom we think may need. For example, like I've said, a young boy, a neonate with a micropenis or with cryptorchidism. In the appropriate clinical setting, the identifications of the presence, absence, or the abnormality of mini-puberty may help identify the etiology of DST. And it not only is it a window of opportunity for identification, but it is a window of opportunity for intervention, like I have given the examples in patients with hypogonadotropic hypogonadism, where the use of gonadotropins not only increases the physical appearance or the descent of the testes, but also increases the testicular volume, thereby increasing the function of the testes, improving the function of the testicular function in the later years, that is in the pubertal years. Thank you.
Thank you, Indira. for your beautiful presentation. You have touched so many areas, and the implication of mini puberty you have highlighted in a very lucid way. One thing I was pondering, the congenital adrenal hyperplasia. What you occur, Indira? Hello?
Yes, sir.
Hello?
Yes, please go on, sir. Yes, I can hear you.
In the in congenital adrenal hyperplasia,
Yes.
and also in congenital some adrenocortical carcinoma, where the adrenaline levels are pretty high. I think in that subsets also, HPJ axis is suppressed because of high level of androgen already from the very onset of neonatal.
So,
And another thing, uh, and another thing which you have very much pointed out, and it's really uh, thought-provoking, that in mini puberty there are windows of opportunity of treating some diseases and the restoring fertility, and also in DSD, the gender assigning, the biological sex. So these are very exciting areas. Previously, it was a gray zone. Mini puberty was a very gray zone. Now, the mini puberty, we are acquiring lots of knowledge, lots of input. So, with this, I invite questions from the postdoctoral trainees or other participants. Dr. Nilanjan Sengupta is there. Nilanjan? Mute করা আছে না unmute? Unmute আছে তো? Mute আছে তো? Hello? Hello?
Hello, yes, sir, you're audible, sir. Sir, I think Nilanjan sir is not there currently in the meeting.
Acha, okay. What is the take of Indira about the points which I alluded? What is her take?
yes, sir. So there are very, I hope my mic is on, yes. So these are important points because we know that, I did not go into the details of that, but we know that the GnRH secretion in males is, let's say, the gonadotropin secretion is tonic, whereas in females it is cyclic. So even in spite of the fact that, let's say, female infants with CAH who have increased exposure to androgens, even in that, the activation of the axis is actually cyclical rather than tonic. And also, again, like I have pointed out, CAIS, or the complete androgen insensitivity syndrome, is very interesting because here, in spite of the fact that, what would I say, that there is absolutely no androgen exposure, but the chromosomal sex being 46XY, the LH-FSH ratio has been found to be of the male type. So there are many other determinants of, let's say, the LH, the FSH, the fluctuations, and also the surges and everything, which needs more and more research and understanding.
And I think in the neonatal period, Indira will agree, LCMS in the urinary measurement of all those LH, FSH, or testosterone, or estrogen, that is a very comfortable and also reliable marker. What is your regarding this, because
So measurement
other
of
module LCMS, I think.
okay, yes, sir. So I had actually referred to this study where the pattern of hormonal reproductive, let's say, hormone secretion in the, let's say, in the normal neonates and in disordered sexual development. I think that JCM article, which we referred to, actually pointed out a lot of things of how we may, what are the findings in a normal child, in a neonate, what could be the findings in somebody who has other forms of DST. Yes, so the hormonal evaluation is will obviously help us decide it.
So postdoctoral training from NRS, have you got any queries or things?
Indira
training.
Dr. Ajitesh here.
Yes, Ajitesh.
Beautiful presentation. So one of the important aspect is because of increased generalized pulsation, pulsatility in pivotal phase, we have to draw blood for full sample. So, but recent days, in these days, because of increased sensitivity and specificity of the assays, we could draw blood in one occasions also. So what's your take on in this message? Because if we want to see minipuberty in this age group, even if you could take 1 ml, 20 minute or 30 minutes interval, but in that case also this was very much problematic, particularly in the non-hospital settings.
Yes.
So should we check for one occasions or should we go for 3 occasions? That means pooled sample.
Actually, it depends on the, what do I say, on the facilities that are available. So repeated occasions may be needed in certain cases, but otherwise in resource limited setting, if the one occasion points to it, then we can.
The cutoff in case of minipuberty is also 0.2?
Yes.
Okay.
0.2.
Okay.
Another question has come. In hypo, which is best treatment, HCG versus HMG versus FSH, and then HCG? And does raise intratesticular testosterone harmful to germ cell? Indira, you take up.
Which is the best treatment, HCG versus HMG versus?
FSH and then HCG.
I think FSH and then HCG is what we prefer. And thus, obviously, supraphysiological doses, supraphysiological dosage of intratesticular testosterone can be harmful to the germ cells.
Yeah. And also that may suppress the axis also, HPG axis. So optimum intratesticular testosterone is necessary. Any other questions from anybody? So if there is no question, we conclude that minipuberty is a very interesting and important area, and what Indira has pointed out, some clinical clues should be in our back of mind. We will have to search for it, and some clinical clues, particularly in the male, there is a distinct the cryptorchidism or the micropenis, etc. So then this should arouse great suspicion, and so we can then embark upon the value test and initiate early treatment. That's very, very important. Another area treatment is delayed, particularly in the males, in future some fertility potential may be lost. In the females, the minipuberty does not have good correlation. That is the important thing. Some idea conjectures are there, but still it is a sort of it remaining elusive. And so the take-home point that you must have a clinical suspicion, clinical eye, proper history taking, so that you can understand the mini-puberty. And there are 3 endocrine puberties already led by Indira, that is HPG, mid-gestational HPG activation, then the mini-puberty, and then the true puberty. These are the things, and one important message that the adolescent that does not develop the androgen receptor. So this stage, etc., does not occur. On the field is groomed. So with this, I conclude by giving a big hand for Indira, very well described, very lucidly described, and the Endocrine Society of Bengal for arranging and giving us the opportunity to interact with a very emerging area, minipuberty.
Thank you, sir.
Thank you, sir. Thank you so much, sir. And thank you, ma'am, for such an informative and comprehensive talk on minipuberty. I'm sure it will be very helpful to all of us.
Thank you.
I thank you, sir, for chairing the session. And also thanks to the Endocrine Society of Bengal for continuing to organize such helpful 4E webinars. Before I conclude, one thing I'd like to share is that the next, just a second. The next 4E webinar that is being held will be on the 23rd of April from 8 p.m. The topic for that is interpretation of growth charts. It will be chaired by Professor Rajesh Khadgawat, who is the professor in the Department of Endocrinology at AIIMS, New Delhi. And the speaker for that webinar is Dr. Ayan Roy, who is the assistant professor in the Department of Endocrinology at AIIMS in Jodhpur. Again, I thank you all for joining the session, and thank you to ma'am and sir for agreeing to being chairperson and speaker for this. Thank you so much.
Thank you.
Thank you.
And now end the meeting.